Assalamu alaikum. Bismillahirrahmanirrahim. We'll discuss iron deficiency. Now we'll discuss iron metabolism, etiology, pathogenesis, and clinical features of iron deficiency anemia and morphological features in the blood film and peripheral blood film. And now, the cause of iron deficiency could be dietary lack, that is, the diet does not contain sufficient amount of iron, or it may be due to impaired absorption of iron in the GI tract, or it may be due to increased requirement, as in the case of pregnancy and in infants when there is a switch of diet from mother's milk to weaning diet, as mother's milk does not contain sufficient amount of iron for us for an infant about 6 months of age, and the requirement should be fulfilled with the weaning diet. So if the weaning is not given properly, then the infants could develop iron deficiency anemia after 6 months of age, or it may be due to chronic blood loss, for example in the case of peptic ulcer or any causing chronic blood loss, or it may be due to menorrhagia causing chronic blood loss. Chronic blood loss is the most common cause of iron deficiency anemia. Iron deficiency anemia could develop due to external hemorrhage, as in the case of trauma, or bleeding into the GI tract, as in the case of peptic ulcer, or carcinoma of the colon, or hematuria resulting from any tumor or any stone in the kidneys, or genital tracts, for example in the females it could be any dysfunctional uterine bleeding could cause iron deficiency anemia that depletes the iron reserves. And iron deficiency anemia in post-menopausal women, when there's no menstrual blood loss monthly, and in men, adult men, is usually due to gastrointestinal blood loss. That is, it could be that peptic ulcer disease, or carcinoma of the colon, or any other GIT loss. Now we'll do iron metabolism first. Total body iron content is about 2 grams in women and 6 grams in men. And it is divided into 2 compartments, functional and storage compartment. Now 80% of the functional iron is found in hemoglobin and myoglobin and iron containing enzymes such as catalase, cytochromes, and about 15 to 20% of the total body iron is stored in the form of ferritin and hemosiderin. Absorption of inorganic iron is enhanced by ascorbic acid, citric acid, amino acid, and sugars in the diet, and it is inhibited by tannates, which is found in the tea, and carbonates, oxalates, and phosphates. Now, Western diet contains about 10 to 20 milligram of iron, and heme is the most absorbable form of iron, which is found in element products, and non-heme iron, which is inorganic iron, is found in the vegetables. Healthy young females have smaller iron stores as compared to men due to monthly loss in the form of menstruation. Now, doing iron metabolism, most ferritin is stored in the within the parenchymal cells in the liver, and in other tissues such as in the spleen and bone marrow. It is mainly found in the macrophages. Normal iron stores have only trace amount of hemosiderin. Mostly it is found in the form of ferritin, and this trace amount of hemosiderin is found in the macrophages in the bone marrow, spleen, and liver. And now dietary iron is absorbed in the proximal duodenum by hepcidin. Hepcidin is actually a small peptide which is synthesized in the liver, and it is released in response to the iron levels in the liver and in the body. If there is increased iron level, the hepcidin binds to it, and then it is endorsed by the enterocytes of the duodenum, and then it is degraded. So this hepcidin actually binds to the receptor which is called ferripotin in the duodenum, and this gets endocytosed in the mucosal cells of the duodenum, and then it gets sloughed off, and in this way the excess iron is lost from the body. And if the body have low iron stores, the hepcidin synthesis falls from the liver, and as a result iron absorption is increased. So this hepcidin actually regulates the iron stores in the body by inhibiting its absorption or facilitating the excretion of iron in the form of sloughing off of the mucosal cells of the. Now, initially, reserves of ferritin and hemosiderin are used which is in the bone marrow and liver and macrophages. They are used whenever the body iron levels are decreased. These stores are used to maintain the iron levels in the body. When these stores are also depleted, then serum iron and transferrin saturation gets low, and erythroid hyperplasia is seen in the bone marrow. And erythroid hyperplasia to increase the formation of RBCs in the bone marrow, so that the deficiency, to overcome the deficiency of iron. Now, hypochromic microcytic anemia appears only when the iron stores are completely depleted, and it is accompanied by low serum iron, ferritin, and transferrin saturation levels. So in the case of iron deficiency, whenever iron deficiency develops due to depletion of iron stores, the iron profile is done, in which we'll see that serum iron level, serum ferritin level is decreased, transferrin saturation levels are decreased, and total iron binding capacity is increased. The bone marrow reveals a mild to moderate increase in erythroid progenitor, and there is disappearance of stainable iron from the macrophages in the bone marrow, and peripheral smears shows hypochromic and microcytic RBCs. Now this picture shows Prussian blue stain of bone marrow. Prussian blue stain is done for iron. Iron is stained with Prussian blue stain, and in the first picture you can see the iron levels are sufficient. In the second picture they are slightly low. In the third left lower picture, iron stores are getting lower, and in the last picture on the lower right side you can see that there is complete absence of iron stores. No blue color is seen, no Prussian blue color is seen. That is, there is absence of iron stores, total absence of iron. Peripheral blood smear, normally what happens that hemoglobin which gives pink color to the RBCs, the RBCs have pink color, and there's only 1/3 of central pallor is seen, which is due to the biconcave shape of the RBC. And when the iron deficiency occurs, this pink color, since hemoglobin becomes low, so the chrome, that is it becomes hypochromic, that is the pink color disappears. There is a central pallor area, is increased central pallor area. Instead of only 1/3, it becomes a large zone, and only a rim of pink color is seen, rim of hemoglobin is seen of RBC. There is a variation in shape of the RBC, that is poikilocytosis, and elongated cells, that is pencil cells are seen in iron deficiency anemia, and there is anisocytosis as well. Anisocytosis is variation in size of the RBC, that is some RBCs are normal in size and some are smaller in size, Now you can see microcytic hypochromic cells in iron deficiency anemia here. You can see pencil-shaped cells and smaller cells which are have only a rim of hemoglobin, and different size, different shapes of the cells are seen in iron deficiency anemia. That is hypochromic microcytic anemia. Now on the left side you can see a normal picture of peripheral blood smear. Here there is lymphocyte, small lymphocyte. Iron, this size of the RBC is almost equal to the size of the small lymphocyte, and in the left picture they are almost equal to the small lymphocyte, and they are normochromic as well. That is, only central one third is paler, the rest is pink in color. That is normochromic normocytic cells are seen here. In the right picture you can see that most of the cells are smaller than the small lymphocytes, that is they are microcytic, and the central paler area is also increased, having only a rim of pink color, rim of hemoglobin, that is they are hypochromic. Hypochromic microcytic cells are seen. Clinical features of iron deficiency anemia are the same, that is the patient is paler and patient is pale, and lethargy occurs and shortness of breath and all this, and it relates to the underlying cause. Sign symptoms are frequently related to the underlying cause, for example bleeding disorder or whatever is the cause. And in severe and long standing iron deficiency anemia, iron containing enzymes are also decreased. As a result, the patient have changes in the hair and nail of the body. Atrophic changes of the tongue is seen, and nail changes is seen in the form of koilonychia, that is spoon-shaped nail is seen. Alopecia, that is loss of hair, is seen. Atrophic changes in the trunk is seen, and gastric mucosa and intestinal malabsorption occurs. And depletion of iron from the central nervous system may lead to appearance of pica. Pica is in which the affected individuals consume non-foodstuffs, and there is central nervous system changes occurs, and the person eats non-foodstuffs such as clay or chalk or like this, which are not normally foodstuffs, and they periodically move their limbs also during sleep, and they may develop Plummer-Vinson syndrome, which is a triad, that is esophageal webs develop, and patient has microcytic hypochromic anemia, and atrophic glossitis develops in severe cases. Now lab diagnosis. In lab diagnosis, both hemoglobin and hematocrit, that is packed cell volume, as well as hemoglobin levels are decreased, and patient and it is usually in moderate degree, and with moderate degree the patient develops changes in the peripheral blood smear as well as in the bone marrow, and there is hypochromia, microcytosis, and poikilocytosis, that is pencil-shaped cells are seen. And when iron profile is done, the patient has low serum iron levels, and ferritin levels are low, and total plasma iron binding capacity is increased. Low serum iron with increased iron binding capacity results in a reduction of transferrin saturation to below 15%. So this was all about iron deficiency anemia. Thank you so much for listening.